Good morning. Now, I want to begin by saying that when I began my career 25, 30 years ago, BPD was seen as a wastebasket category, particularly by George, who liked to say that one resident's wife was another's, one resident's borderline patient was another's wife, and that was seen as very humorous. But now, according to the criteria of Robbins and Gouset, BPD can be delimited from other psychiatric disorders. Something of its etiology, both environmental and biological, is known. It definitely runs in families, and it has a complex but increasingly known course, which I hope to speak about today in a way that's useful to you clinically. And BPD is now recognized as a common disorder. About 2% of American adults meet criteria for BPD. The range is 1.6 to 5.9. It's about as common as bipolar I disorder, so it's a very serious public health problem, and it's more common than schizophrenia. Now, there's a continuum of borderline psychopathology, something which I strangely did not particularly in a feeling way recognize, because like most people, I was partly trained in a hospital where you only see the patients who keep coming back and you never see the ones who get better. But in reality, some people with BPD recover spontaneously and are never patients. And some use non-intensive outpatient treatment and are never hospitalized, and others become severely ill and use large amounts of mental health services, including repeated inpatient stays. Now, the latter group, for the reason I described, has defined BPD for generations of clinicians. I should also say that the trouble with meeting patients in the hospital is it's the worst day of their life, and none of us look good when we have to beg a nurse to go anywhere, to use the phone, and so on. So the story of BPD is in some ways the story of young adults being trapped with other young adults, better known as the treatment team, in a tiny, awkward, relatively shabby place, everyone trying to get their needs met in hopefully graceful but almost invariably awkward ways. But until recently, most or much of research has focused on inpatient-level patients. That's no longer true. But this presentation today primarily deals with this type of severely ill patient. Now, I'm going to talk about the McLean study of adult development, MSAD. I'm not just going to tell you what I found, but I'm going to tell you a little bit. It's not only a study about BPD over time, it's a talk about a study over time, because we went down some pathways that we discovered were not particularly perfectly true. Anyway, it was the first NIMH-funded prospective study of the longitudinal course of BPD. We began with 362 McLean inpatients, and I have to say that these people represent a broad socioeconomic spectrum. This is not the McLean of old. This was the McLean in the 1990s, and their average length of index admission was 6 days. We put our short-term admission unit next to our largest parking lot with a clear message that, welcome and goodbye. We've completed, I'm going to talk today about 8 waves of blind follow-up that are complete, 2 through 16-year data. Our 18 and 20-year waves are 99% complete. We're waiting for 3 people who've had really, one woman in particular has had something really terrible happen to her. So we're waiting till she's a little bit more steady to interview her. Our 22-year wave is 94% complete, and our 24-year wave began in about a year ago in July of 2016. So we're talking about, I'm going to be focusing mostly on 16-year wave data, but basically this is a quarter-century study. Now, our subjects were 290 patients meeting both DIB-R and DSM-3R criteria for BPD, and the DIB-R is the revised diagnostic interview for borderlines. And when I began working with John Gunderson in my first year as a graduate student, he had an instrument called the DIB, which I read, didn't like, and said, gee, I think I'll rewrite this and make it better. And he looked at me with a little bit of surprise and said, oh, okay. And so I changed it all around, and I've been using it ever since and sending it around the world. So thank you, John Gunderson. We also studied 72 Axis 2 comparison subjects, also hospitalized, meeting DSM-3R criteria for another personality disorder, but neither study criteria set for BPD. And in the reality, in the 6 days these people were admitted, none of the psychiatrists in charge knew who was borderline and who wasn't, because all of these young adults were angry, suicidal, depressed, and in many ways charming and engaging. Now the DIBR, let me tell you a little bit about it. Unlike the DSM, where we've heard many descriptions that there are hundreds of ways of meeting criteria, in the DIBR that's not so. We study dysphoric affects of a chronic nature, disturbed cognition, impulsive behaviors, and troubled relationships. And what's different is that you have to have symptoms in each of these 4 domains, and that it results in a somewhat smaller but much more homogeneous group of patients than the DSM criteria. And since MSAD began, I've done a lot of studies with outpatients or symptomatic volunteers, and there are plenty of folks out there who meet these stringent criteria, because we study 22 symptoms, not the 8 or 9 of the DSM. And what's interesting is that there are really 3 types of borderline patients. We're studying the people who are truly troubled. Then there's a group that is sort of troubled but can use therapy, but they have a quieter life, maybe a life of desperation. And then there are the people who really can use treatment, who see themselves as having a disorder and can work quite well with you. And they all would meet these rigorous criteria. So all borderlines are not the same. Now, of course, there were earlier studies before MSAD of the course of borderline personality disorder. There were 17 small-scale prospective studies of the short-term course of BPD. I believe they were from 1 to 7 years in length. And the results of these studies were taken to mean that patients with BPD do poorly in the short run, which is not totally true. And there were 4 large-scale follow-back studies of the long-term course of BPD. And follow-back studies simply mean you go back into your medical records department with the team and root through the charts and come up with a chart-based diagnosis. There was Tom McLaughlin's study at Chestnut Lodge, which no longer exists. Mike Stone's study at the New York State Psychiatric Institute, Joel Paris, who's here today, the Jewish General Hospital in Montreal, and Eric Plakin, who may be here today, at Austin Riggs. And the results of these studies were taken to mean that patients with BPD do substantially better in the long run, which is also somewhat true and not true. Now, there are limitations, and you might say, oh my God, this woman's going to go on about methodology. Where can I go to get a snack? The reality is they used chart review or clinical interviews to diagnose BPD. Semi-structured interviews may be duller, but they're more reliable. And surprisingly, patients with a DIBR, for example, I've actually had patients say, how did you know, when I asked them the questions, or did you write this just for me? Which is touching and surprising. Basically, some of these studies had no comparison group or the use of less than optimal comparison subjects, such as persons meeting criteria for schizophrenia. They relied on small-size samples with high attrition rates, and this, in part, I think, was due to the fact that many of these studies, if not most or all, were actually not funded by a government or a foundation source. They were actually paid for by the home hospital. So that's truly a model that we may be going back to, but we had escaped from it for a while. Basically, other limitations were that only very basic data was collected at baseline and follow-up in most of these studies, sometimes 2 or 3 variables. Typically, only 1 post-baseline reassessment. Joel Paris is the only one who first studied his subjects at about 15 years and then followed them up again at 27 years. Sometimes there was a non-blind post-baseline assessment, and there were also a variable number of years of follow-up in the same study. For example, in one of these studies, the people had been discharged from that hospital anywhere from 2 to 32 years prior to so it made the data analyses and the whole thing sort of intriguing. I should also say 3 of the 4 samples were from economically privileged groups who were at basically self-pay institutions. Now, this starts the study of, or the story of how MSAD unfolded. We've published extensively at 4 different time points in the study: baseline, 6-year follow-up, 10-year follow-up, and 16-year follow-up, and I want to take you through this a bit. We've also had over 90 peer-reviewed articles. Now, at baseline, two of the things we found most interesting was that some, but not all, borderline patients, the disorder seems to begin in childhood. They reported that their age they first felt emotionally ill was about 11. We didn't specify what emotionally ill was, but that's a very young age, and the same sample did not actually seek treatment until 17, 18. So there was a huge lag, and it was a time when they could start to develop the idea not that they were ill, but that they were bad or evil or caused all their problems in their family. And I do think that even though they were using immature defenses, they also were suffering, and suffering a great deal because they didn't understand why they were so off-putting to people. We also found along the same line of childhood onset that a third of borderline patients who had a history of self-mutilation at baseline, that was 91% of our sample had a history of self-harm, began to harm themselves in latency or earlier, 12 or younger, and another 30% first harmed themselves as adolescents, 13 to 17. Now, this is a 25-year-old study, but if you think that these people, it was 35, 45 years ago or more, that they were children or adolescents, these behaviors simply were not known almost 25 years ago. And so they were engaged in it as a solipsistic form of self-soothing rather than being iatrogenic in nature. For many people, these are not learned forms of behavior in a psychiatric setting, and their main purpose is not to torture treaters. I think its main purpose is to calm the person down and also to communicate awkwardly that they need help. Borderline patients tend to believe they're masters of communication when they're actually masters of misdirection and indirect communication. I've had patients leave my office, slam the door, say a few choice words that I could hear through the door, and then come back and knock on the door 5 minutes later and look at me, and I'll say, "Were you trying to ask for an extra appointment?" And they'll say, "Yes, how did you know?" And then a few more choice words. But they got what they wanted, but my door does not shut now because of all the people slamming it. At 6 year, we thought, wow, this is great. There seemed to be, it seems to support a very optimistic view of the course of BPD for almost everyone. Rates of BPD symptoms declined significantly, and we studied 24. We also studied the 2 that are not in the DIB, affective lability and serious identity disturbance. The rates of co-occurring disorders were going way down. Remissions of BPD occurred at a much higher rate than expected. Psychosocial functioning improved. Restrictive forms of treatment were less common. People were not being hospitalized as often, having to go to a halfway house or a day program. But then we started, as we were in the 6-year data, but also as we moved to the 10-year data, we started to be a little more realistic that there are really subtypes of borderline patients. We began studying physical health, health-related lifestyle choices, and use of costly forms of medical care at 6-year follow-up. And we found that never remitted borderline patients had worse physical health, took poorer care of themselves, and went to the ER medically or hospitalized for medical reasons at significantly higher rates than ever remitted borderline patients. And this was a finding that we've also replicated at 16-year follow-up using a different variable to define the groups. We also started looking and thinking about psychosocial functioning a little more at 10-year follow-up. We had been defining this outcome broadly as having at least one emotionally sustaining relationship with a non-relative, a friend, a spouse, and functioning well at work or school. However, we developed at this point a more narrow definition that required full-time work or school because so many of the people who were on disability were working so part-time, doing things like babysitting or dog walking, and they really didn't really capture a full life in our estimation. Actually, 82% of these borderline patients achieved a broad definition of good psychosocial functioning, but only 60% achieved the narrow definition of good psychosocial functioning because of requiring full-time work or school. And we've gone with that definition ever since. Now, our retention has been high. 88% of surviving borderline patients were still participating at 16-year follow-up, and 83% of surviving access to comparison subjects were still participating. And borderline patients obviously have a reputation as being difficult. However, they certainly are able to give informed consent. They're very good at no, but they're also surprisingly loyal and good at saying yes. I've been blessed with some socially extraordinarily skilled research assistants who are able to really provide people with experiences that were not only not traumatic, but I received letters or phone calls praising these people for helping them chart the course of their life and see how they were doing. I've also always sent out the letters for every wave under or with my own name and my own phone number, my own email address, so people can call in. And now we're all getting so much older that I've had subjects start to say to me, I've known you longer than anyone since my parents. And so we're all in this together. Now here's the first piece of good news at 16-year follow-up. Symptomatic remissions of BPD, and that means not meeting either criteria set for BPD that define this study, which is DIB-R and DSM-3R, are common and relatively stable. 99% of borderline patients achieve a 2-year remission, 95% achieve a 4-year remission, 90% achieve a 6-year remission, and 78% achieve an 8-year remission. Now, this is not something I think people thought was coming down the pike, and when I first started presenting these results, people didn't believe me, or they came up with all kinds of excuses, and then finally, because I just kept presenting it, they just collapsed and accepted it. Although that may be true at academic medical centers and in places like this, I'm not sure it's really reached most places that these patients stand a very good chance, at least symptomatically, and I'll get into more detail in areas where they're having more trouble. Now, recurrences of BPD are actually relatively rare. After remissions lasting 2 years, 36% of patients have a recurrence. After remissions lasting 4 years, about a quarter. After remissions lasting 6 years, about 20%. And after remissions lasting 8 years, about 10%. So the course of BPD is very different from that of mood disorders, let's say major depression, where remission occurs much more rapidly, but recurrences are more common. In Marty Keller's work, basically almost everybody who entered his study of depression had a recurrence, which is not a surprise. But with BPD, it's more like it's not a chronic disorder for most people. It's a slowly evolving disorder that has more to do with growing up, a point that George made, than being treated with a particular medication or some fantastic therapy. That basically what these people, and you'll see it, what they seem to need and what they get is they finally figure out that we only get one childhood, but there are many adult reparations out there for us. Those of us who've had a tough time, if we can find a spouse who's somewhat more mature than we are, if we can find something we're really good at, we'll pick up steam and move forward. And so many people in the study have found those two things, and about 40% haven't, and we'll talk about both groups. Now, completed suicide up to 16-year, 4.5% of borderline patients, and that was mostly in the period right after their hospitalization, their index admission, which is substantially less than the 9 to 10% found in 2 of the 3 follow-back studies conducted in the 1980s that assessed this outcome. And we've suggested or thought that treatments may be more appropriately supportive. People are no longer engaging borderline patients in very intensive psychodynamically oriented treatment that may, because of their style, feel like an attack on them or just irrelevant. And something a bit more supportive can be useful. And we're also now more sensitive to childhood adversity. And adversity doesn't have to mean sexual abuse. All borderline patients have not been sexually abused. But it can mean an unfortunate admixture of a sensitive child's nature and parents who don't realize that they're dealing with a psychiatrically ill child. They instead see themselves as dealing with an unruly child. Now, another study which I was involved in, which John Gunderson led at Harvard and was also conducted at Brown, at Yale, and Columbia, the Collaborative Longitudinal Personality Disorders Study, or CLPS, which was also NIMH funded. It completed 10 years of follow-up and has been completed for about the last 8 to 9 years. Had similar symptomatic findings, so we're not just out there finding something by ourselves. In an important paper, Gunderson reported that 85% of borderline patients had a 12-month remission. If it was a 12-year remission, I'd really be envious. And 11% had a recurrence. So it's really the same idea. You get well and you stay well. Now, this model, a complex model of borderline psychopathology, has guided our work really since we wrote a paper on this in 1994. And some of you are so young you might not have been alive at that point, as some of my newer research assistants have actually mentioned that they have trouble with some of the patients because they literally were not alive when the people first began the study. Anyway, in this model, hyperbolic temperament is the outward face of the neurobiological dimensions that underlie borderline psychopathology. And a hyperbolic temperament relies on the defense of emotional hypochondriasis. And what this is a very sensitive person who takes umbrage at just about everything. And that's a lot of us. But what's different about them is they're insistent and persistent that we pay attention to their pain, but they both expose it and hide it at the same time, so that we're left in the awkward position of not knowing what's happening or how to address it, particularly so that we can have a graceful exchange with them and they don't feel even worse about themselves than they already do. In this model, after kindling of some kind, which can be normative, going off to college, or traumatic, being date raped, acute and temperamental symptoms develop. Now, acute symptoms of BPD resolve relatively rapidly. They're the best markers for the disorder because they're the most colorful symptoms, and they're also the symptoms that are almost pathognomonic for the disorder, at least several of them. They're often the main reason for expensive forms of psychiatric care, such as inpatient stays, and they're akin to the positive symptoms of schizophrenia. Temperamental symptoms resolve relatively slowly. They're not specific to BPD. Many of us in the room have one or two of these symptoms. They're associated with ongoing psychosocial impairment, which is key, and they're akin to the negative symptoms of schizophrenia. They're what's left after the acute phase of the disorder is over. Now, examples of these symptoms, acute symptoms, self-harm or self-mutilation, suicide efforts, quasi-psychotic thought, temperamental symptoms, being angry, feeling angry and acting angry, distrust and suspiciousness, which tend to be chronic in borderline patients, and abandonment concerns. Now, this is a figure to sort of show the difference between anger, which is a temperamental symptom, and self-harm, which is an acute symptom. You can see that they both go down by 16-year follow-up, and a lot for the people who had them at baseline, but self-mutilation goes down far more. Same type of model can be seen for intolerance of aloneness, which is a temperamental symptom in our model, and suicide efforts, which is an acute symptom. Now, it turns out, I'm not going to go into the details because they're both hard to remember, and I'm sure it would be a new form of sleep medication as to how we discern this mathematically. But it turns out that 12 symptoms were found to be acute in nature, and 12 were found to be temperamental in nature, which is both symmetrical and, I think, true. Now, I'm going to go over these. You might say, why is this woman droning on about these symptoms? The reason is they can really inform treatment. If you know that some symptoms are going to remit rapidly with treatment as usual, that can give you something to hold on to, because they tend to be the scarier treatments that both annoy clinicians and frighten them. And the temperamental symptoms, which resolve more slowly, often can be overlooked and simply excused as somebody's temperament, but in reality attention must be paid to them as well if the person's going to have a life. Just because the patient shows up, isn't hospitalized, if their life consists of a 14-year-old cat, which some of our subjects have, and we've wondered if we could get a little tiny defibrillator if there was a cardiac event during the interview, the person's life isn't quite what she expected it to be. Now, the acute symptoms, only one symptom of an affective nature is acute, and that's affective instability. This is Marshall Linehan's emotion dysregulation, and I think it's interesting that it's one of the ones that it resolves the most rapidly. But when you think about it, how we all were in a dither in high school and college, and then by the time we were a bit older, things didn't upset us as much because we'd seen it before, we knew how to handle it. Life isn't so surprising the older you get. It's like at a certain age, there's almost nothing new, except your own death, which you will not be around to experience. Cognitive symptoms, quasi-psychotic thought, serious identity disturbance. You might say, what's serious identity disturbance doing in there? It's because it's propped up by overvalued ideas of being bad, worthless, evil. Impulsive symptoms, substance abuse drops right off, promiscuity drops right off, self-harm goes down rapidly, as does suicide threats and attempts. Now, interpersonal symptoms of an acute nature, stormy relationships, fighting with people, breaking up with people, being devaluative, manipulative, cruel, being demanding or entitled, serious treatment regressions. For example, these are the patients for whom treatment is toxic. A patient who's never done anything like this will suddenly become very aggressive on an inpatient unit when they're there for the first time. Countertransference problems, therapists or often mental health workers and nurses loathe these people. And special treatment relationships that actually go the other way, and people become inappropriately involved in a friendship or love affair, which is always a complete disaster. But what I think, rather than, some people don't want this in the instrument because they said, I'm being mean and calling people names. I think this is just reality. But what's important is that these aren't forms of misbehavior. They're really outmoded survival strategies rather than forms of misbehavior. These are things that worked when these people were younger. They just don't work anymore. Think of your children. What behaviors, who hasn't had a manipulative or demanding child? But we don't think of it as psychopathology. They're just little and powerless. They're doing the best they can, and so are these people. But they can be taught and helped with support to behave in a much more graceful manner in a relatively short period of time, although that short period of time is years. And I have to say, being a longitudinal researcher, I also am very happy watching grass grow, so that I'm not a restless person, and it helps. Now, temperamental symptoms of an affective nature, almost all affective symptoms other than lability are temperamental in nature. We have people with a lot of chronic feelings of depression, helplessness, hopelessness, worthlessness, anger, anxiety, loneliness, emptiness, cognitive symptoms that go on, odd thought, for example, overvalued ideas, but often of being ugly, stupid, something like that. And an unusual perceptual experiences, for example, depersonalization, which in only about a third of the people is actually of a serious nature, and non-delusional paranoia. And impulsive symptoms that are temperamental in nature, everything that hasn't been mentioned already. So, for example, eating binges, spending sprees, reckless driving. And these are the quiet interpersonal symptoms that don't bother therapists, but that destroy someone's ability to work. Intolerance of aloneness, abandonment, engulfment, annihilation concerns. I read Jerry Adler and Dan Bowie's famous book on the uses and misuses of confrontation when I was a graduate student, and this is my memorial item to them. Counterdependency, somebody's always volunteering to help others, doesn't like to be helped, and at the same time, they're very dependent and let people push them around or use them. Now, the symptoms that resolve most rapidly, just to put this together more in a synthetic way, are those reflecting core areas of impulsivity, for example, self-harm and suicide efforts. And again, these behaviors in part may have a iatrogenic meaning, but these are old forms of behavior for many people that they developed on their own. Many of the people who said they started first self-harm as latency-age children described hitting themselves in the face with a hammer, dropping a dresser on themselves and trying to bruise the entire front of their body, or sticking their arm in a door and slamming the door on it, and then actually sort of letting their parents know they were black and blue and damaged, and their parents would often say, maybe because they were tired or depressed or their business was collapsing, not because they were bad people. I think you'll be fine if you put a washcloth on it or something, and the patient was hoping for something more. And these forms of behavior in some patients, the sickest patients, are actually an addiction. And just like addiction to drugs or tobacco or other drugs other than tobacco, basically it's hard to give up an addiction. It's sort of work for you. And also symptoms that resolve most rapidly are active attempts to manage interpersonal difficulties. For example, as I mentioned before, stormy relationships and devaluation, manipulation, or cruelty. The most stable symptoms are affective symptoms reflecting areas of chronic dysphoria, again, anger, loneliness, emptiness, interpersonal symptoms reflecting abandonment and dependency issues, intolerance of aloneness, counterdependency problems. Now, something that's really important is we did the first study of symptomatic recurrence, which you can find in the American Journal of Psychiatry in 2016, and the acute symptoms were not only more likely to remit and remit more rapidly, but they were less likely to recur, which runs counter to beliefs held by many clinicians. And this is super good news, which means the person who you're terrified of today, in all probability, their self-harm will disappear over time and not reappear. And nothing could be better. The problem is that the more quiet symptoms of BPD will reappear. In many ways, perhaps didn't really leave. Now, symptoms in CLPS has a similar division of symptoms, excuse me, that was termed a hybrid model. And could I have some water right there? Thank you. By Tom McLean, and in this model, PDs are comprised of symptomatic behaviors and traits, which are similar to acute and temperamental symptoms, respectively. Now, this is a very important area that's both good news and somewhat guarded news. Recovery is defined as having a concurrent remission from BPD and good social and vocational functioning. And this psychosocial functioning, as mentioned before, is defined as at least one emotionally sustaining relationship with a friend or romantic partner, not a relative, and a good vocational performance, a sustained vocational history, and full-time vocational engagement. It's much more difficult to attain than symptomatic remission, particularly sustained recoveries lasting 4 to 8 years. 60% achieve a 2-year recovery, 54% achieve a 4-year recovery, 44% achieve a 6-year recovery, and 40% achieve an 8-year recovery. And loss of recovery is also somewhat more common than symptomatic recurrences. After recoveries lasting 2 years, 44% of people see a loss of their recovery. After recoveries lasting 4 years, about a third see a loss of their recovery. After recoveries lasting 6 years, 26% or a quarter see a loss of their recovery. And after recoveries lasting 8 years, about 20% see a loss of their recoveries. Now, the reasons for the difficulty attaining or maintaining recovery: inability to work or go to school consistently and competently and on a full-time basis. And this brings up the issue of disability. About 40% of our subjects are on disability at any one time. They don't know, they're not able to tell us why they're on disability. It could be for a physical reason, it could be for a psychiatric reason. They're not sure what was on the piece of paper the doctor signed. I'm sure not many people, doctors sign borderline personality disorder. And I think it's a double-edged sword. It may be why our rate of suicide is less high than expected. It could also be really a gateway to a much more limited life, because in some ways people perceive it as not that their doctors see them as a chronic patient, but their families have given up on them. So it's something to really think about. I had a patient who I saw for 10 years. He was the angriest, smallest male borderline patient. And for 10 years, he insisted he only came to his sessions, which he always came to and on time, because he was made to. And no matter how many times I asked him who made him come, he wasn't able to answer that. And our battle was, I thought he should go to work, he thought he should be on disability, and he went to work. And in many ways, it changed his life because it gave his life structure, and he could also start to look at the fact that he had friends all the way through childhood and adolescence, but as his friends started to get married and move on to careers, he just couldn't go there, and to work on why he couldn't go there. And he was ashamed of how, in many ways, he was still a boy, not a man. Now, let's talk about the Access to comparison subjects a bit. Again, these were people, men and women, who their doctors could not, during the index admission, say what disorder they had. But they have more stable rates of symptomatic remission. Both groups, borderlines and comparison subjects, have a 99% of a 2-year remission, but 97% have an 8-year remission for the comparison subjects versus 70%, versus 78% of the borderline patients. And they have higher and much more stable rates of recovery. 85% rather than 60% have a 2-year recovery, and 75% rather than 40% have an 8-year recovery. So they're doing much better. So BPD can be distinguished from other disorders, and other disorders where people end up in the hospital tend to be less severe. Now, let's talk about predictors of time to recovery from borderline personality disorder. This is our multivariate model. No prior hospitalizations, a good vocational history in the 2-year, or school history in the 2 years prior to admission, a higher but not necessarily a high IQ, no anxious cluster personality disorder, so nobody was avoidant or dependent, higher trait extroversion, which, as all of us who know the NEO know, this is not just being outgoing, it's also having positive emotions that you're just that you can use, and higher trait agreeableness, which doesn't just mean that you would agree to everything. It actually means you have some capacity to mentalize, that you can sort of figure out what other people want and what would be the graceful thing to do and decide to do it. Now, the nature of the significant predictors: lack of chronicity, no prior hospitalizations, competence, good vocational history and a higher IQ, temperament, lower avoidance, and higher positive emotion and compassion for others, which is at its essence what agreeableness actually is, not just that you're a doormat for other people. What's perhaps more important is what was not significant as a predictor. Childhood adversity seemed to have no relationship in this model, and we looked at sexual abuse, severity of other forms of abuse, and severity of neglect. We also looked at adult adversity, physical and or sexual assault, family history of psychiatric disorder, and these families had a lot of psychiatric disorder, mostly depression and alcoholism. And interestingly enough, no Axis 1 psychopathology. So what does this really say? It really says, and we've done predictive models at an earlier time point for remission, is that it isn't what people have done to you or haven't done for you that leads you to recover or not recover. It's really who you essentially are, and over time, who you essentially add to your life and what you can prove to yourself you can do. In many ways, it reinforces George's earlier findings with 3 different samples, 2 of men and 1 of women. And so, again, I think it makes us both clinically more hopeful and also more modest that wonderful, brilliant thing we said, was maybe neither so wonderful nor so brilliant, but it was maybe useful. Now, most of the subjects in this study were treated in the community. They were seen by psychologists, social workers, counselors for therapy, and that was almost always treatment as usual. There were no empirically based treatments when the study began, except Marshall Linehan's first paper had come out at about the same time the study started. About 70% of patients with BPD have been in individual therapy and taking standing medications during all 8 follow-up periods. I'm not sure that this has been needed, but I think these are very affiliated patients, and they hate to give up relationships with people they like and trust, so they stay around. And it may also be some kind of magical touching of the stone. Individual therapies at this point, most people still see their therapist once a week, but some people see them a couple of times a year. And our rate of hospitalization has declined to 24% at 16-year follow-up, and it tends to be the people with the most severe trauma histories. Now, Paul Links, many years ago, who at that time was at was at McMaster, said that some borderline patients may need to be treated with a rehabilitation model as they have difficulty working consistently and competently. They also have trouble managing everyday tasks. Many of them, for example, don't know how to use an ATM machine, or to budget, or to shop for groceries, or to drive a car, which is unfortunate. But what I've tried to do over the years was to hire mental health workers to serve as guides, people the same age who are a bit more competent, to teach them all these things, and it seems to work out very well. Rather than just telling them, hey, why don't you just go to the ATM and do it, somebody takes them there, shows them how to do it, and so they sort of feel it's a bit of a social event, but it's also known to be, the people I've picked have been particularly warm and supportive, and so there's no sense of shame in learning something a little late in life. Paul also suggests this model because so many of these patients back away from anxiety-provoking situations, including the social as well as the vocational realm, and they struggle with sleep and pain management. Co-investigators of ours, David Plan in the area of sleep, Robert Biskin in the area of pain, have found that these people suffer high rates of insomnia and are in a lot of physical pain. Now, individual therapy, as we all know, there are now 5 empirically based individual therapies for BPD, and they tend to focus on the acute symptoms of BPD. Marshall Linehan's DBT, Anthony Bateman and Peter Fonagy's MBT, Otto Kernberg and Ken Levy and John Clarkin's TFP, schema-focused therapy, which is more common in Europe than in the US, and general psychiatric management, which was developed by Shelley McLean and Paul Links. And I believe we need empirically based individual therapies which focus on the temperamental symptoms of BPD. And target areas should include, as George mentioned, increasing grit and other positive traits, which actually can be taught to school children, and under Angela Duckworth's careful observation are actually being implemented in schools to try to make children more resilient and have more perseverance. And decreasing experiential avoidance. And this is the one that I think really has led to 40% of our people not recovering. That they're not only highly anxious, many people are highly anxious, including many of us in this room, but we just sort of blast through it. But if you tend to back away, pretty soon your life is much smaller and more limited than you had ever planned, and it's very hard to break the symptom at all. I have a patient who exemplifies this, and we've talked about how small her life is, and she said basically this is her choice, and she would rather have a small life that's not very satisfying than risk being highly anxious and in any way bringing up her trauma history, which began at the age of about 3. Now, polypharmacy among these patients is extremely common. Right throughout all the waves of follow-up, about 40% of our borderline patients have been on 3 or more standing medications, about 20% have been on 4 or more standing medications, and about 5 have been on, or 10% have been on 5 or more standing medications. It's impossible to know when you have polypharmacy if anything's working, because it's just such an interaction. And it also can confuse people. I remember working with a resident who told me that this patient I was seeing basically had always been a middle-aged failure, which seems odd to me that she would start life as a middle-aged person, but still, we went to the medical records department, and it turns out she had been chief nurse of one of Boston's foremost teaching hospitals and had fallen ill as she was older. But she was treated with massive amounts of medication. And the patients say, they're somewhat useful. They're not dancing in the streets about these medications. And I think a lot of it is that they're very attached to their psychopharmacologist, who's very attentive, tries this and that combination. But there certainly are borderline patients who are deeply biologically depressed, for example. But there are also many others who are demoralized. They're demoralized because the life doesn't have in it what they would like. They don't have the relationships they would like. They don't have the work they would like. are disappointed in themselves or ashamed of themselves, and other families are also disappointed in them. And it's not plain what exactly is being medicated. Is this BPD? Is this a comorbid disorder? Is this a combination of the two? Interestingly enough, they always end up with the very latest medications. They never are taking generics. And it's simply amazing. But the reality is there's no empirical evidence for the efficacy of polypharmacy and BPD. Our group is the only group that ever studied monotherapy versus polypharmacy. And what we discovered is the results were exactly the same in borderline patients. This was a randomized controlled trial. However, it is associated with high rates of obesity. In our sample at this point, we've got people with BMIs of 58, 60. These are not BMIs consistent with life. And in fact, we've had 3 separate people say to us when we would say, well, we'll see you in 2 years, they said, I don't think I'll be alive. I can't get bariatric surgery because I can't lose weight on my own. And in fact, each of them was dead by the next follow-up period. So polypharmacy may be an effective treatment. It can also be something that's extremely bad for people's health. And just as we all only get one mind, we only get one body. And it's statistically associated with osteoarthritis, diabetes, hypertension, chronic back pain, urinary incontinence, GERD, and gallstones. Now, other healthcare findings. Non-recovered borderline patients are in worse physical health than recovered borderline patients. And we used to use remitted, non-remitted, now non-recovered versus recovered because it's roughly 50-50 of the sample. And here's an example, 37% of the non-recovered patients versus 16% of the recovered patients had a poorly understood syndrome such as fibromyalgia, chronic fatigue. They're more likely to make poor health-related lifestyle choices, 34% versus 16% are smoking a pack of cigarettes a day, including people with COPD who are still smoking. And they use costly forms of medical care. 40% versus 17% had a medical hospitalization, and we did not include having a baby. These were for ailments, not a positive life experience. And a substantial, this is interesting in particular with all the publicity about this, a substantial percentage of borderline patients use opioid medication without abusing it to alleviate the chronic pain of osteoarthritis, fibromyalgia, and back pain. They're almost twice as likely to use opioids in this way as access to comparison subjects, and they report that this use of opioids allows them to function better at work and at home. Now, we've questioned them up and down about doctor shopping, all of this type of stuff. They say, no, my PCP gives me this medication, and there's been no evidence of moving toward abusing heroin or fentanyl or anything else. Whether this is a particularly good treatment for chronic pain is another issue, but the substance abuse doctors at McLean have said that this is what they found, that basically 90% of people who have some kind of chronic pain condition can use opioids without going to abuse, and 10% will go very rapidly to abuse. And the issue would seem to me to be to try to figure out beforehand who might be going rapidly toward abuse. Now, other health findings is that 98% of borderline patients and access to comparison subjects have health insurance. Now, this percentage is not surprising as Massachusetts has an almost universal coverage. However, a substantial percentage live in other states. So these people, and about half have private insurance, about half have public insurance, Medicaid, or Medicare, or both, basically are somehow able to get their needs met. And I think they're particularly good at working with the disability system because, unlike people with schizophrenia and so on for whom the system was developed, they're very good at explaining to people what's wrong with them and showing that their long list of hospitalizations, gathering the paperwork together. And again, whether disability payments are useful or not useful or both, but at different times in a person's life is hard to know. Now, going all the way through partially completed 24-year data, and Christine Temmes will be talking much more about this in another venue here. 5.5% of borderline patients have committed suicide, and 7.9% have died of natural causes or accidents that they, in 2 of the 3 cases, did not cause over the course of the study to date. And in comparison, only 1 comparison subject has committed suicide, and that was right after his index admission, and 3 others have died of other causes, and 2 of those people have died of cancer, I believe. Now let's review what we found. 99% of patients with BPD experience a remission of their BPD, and recurrences of BPD are relatively rare. Why people aren't dancing in the street and instead are still groaning and moaning about borderline patients is puzzling, and I guess it's because the journey is so bumpy and so long, and it is a lot like having many adolescent children. And in fact, when you're studying 400 adolescent children, it can sometimes be overwhelming. But people, this is the main medical goal of treatment, which is remission. And BPD seems to be comprised of 2 types of symptoms which can inform your treatment. The acute symptoms, which people dread treating, actually will get better relatively quickly, as long as I think, and John Gunderson pointed this out years and years ago, as long as a borderline patient feels held, they won't be particularly symptomatic. They start to get symptomatic if they're worried about abandonment. And when they feel they have been abandoned, then symptoms like self-harm will present themselves. Temperamental symptoms, which don't bother clinicians, as I mentioned, because they're sort of quiet, actually are the ones that will prevent them. You can cut yourself and still be a doctor if you have BPD. But if you have tremendous experiential avoidance, you're not going to be able to be a doctor because it's simply anxiety-provoking to be one. Now, recovery from BPD is more difficult to attain than remission from BPD alone, and if we had opened it up to our broad definition, it would look much better, but I think this is more honest or realistic. And it's relatively stable once attained. Now, completed suicide is substantially less common than the expected 10%, and as I mentioned before, this may be due to more trauma-sensitive or supportive treatments. And prediction of time to recovery is multifactorial in nature. It involves factors that are routinely assessed in treatment, such as work history, and other factors, particularly aspects of temperament, that are not. Now, just before I get to my conclusions, I just want to point out sort of what the predictive model showed. Basically, I think the subtypes, and we're going to look into this more with our additional waves of data, is that the subtypes aren't just remitted, non-remitted, recovered, not recovered. It's really, I do believe, and we have these instruments now in our battery, how gritty you are and how little you have experiential avoidance. It's basically who you are. All borderline patients do not have the same total personality package, and they also don't all have the same ability. The ones who recover feel they have an illness and they're going to fight it and get better. The ones who don't recover end up in a chronic patient role, which they're able to accept, and they stop struggling against their illness. And maybe that's okay. Maybe that's the best they can do. But it's important to at least think about, what kind of patient do I have in my office? Is this somebody who I think could really have a fighting spirit to overcome this illness, or is this someone so quiet and so hurt and so passive that she can't do it? And my job would be to support her in this quieter adaptation, but it involves never getting readmitted and it being in pretty good physical health and so on. Now, in conclusion, the symptomatic course, particularly for acute symptoms, is substantially better than previously known, and other areas such as vocational functioning and physical health have a more guarded outcome. However, it is important to remember that BPD is a disorder with a dignity and power all its own. After all, not many people remain so loyal to their emotional pain and their difficult past. Thank you very much. Questions? Apparently, we have time for one question. Is there a question? Joel?
About affective instability.
Yes.
You don't call it temperamental, but it is a heritable trait that has been shown, and it may even have a unique pathophysiology, as some of Königsberg's work suggests. And I wonder how you measured it, how sure you are that it goes away after acute episodes.
We measured it by assessing it every 2 years. It doesn't really mean that which trait is biological, which is. I don't think we know very much about that for all of these symptoms. I'm simply reporting to you how rapidly something went away and stayed away. And that's my answer. Do we have time for Stephanie, too?
It's actually related to the question. Part B. So, you mentioned that there were the affect components, so a lot of them, like, depression, anger, anxiety. Those things are more temperamental.
Right.
I was wondering if you could comment on, I don't know, maybe what you thought about the difference there and people's experience of having those sort of core negative affects be sort of temperamental and sort of an affective ability limited.
Okay. I think borderline patients, as I mentioned before, are not happy campers who just enjoy making our lives a living hell. I think they are suffering, and suffering deeply throughout their lives oftentimes, and don't realize they're sick. Many people have told me they thought they were simply evil or totally bad, and are relieved to receive the borderline diagnosis. Hint, give the person the diagnosis. I think they have chronic dysphoria, but affective lability really is swinging from one thing to another, and the swings become less common and their amplitude goes down so that they're not as moody as we were. Many of us were well-loved adolescent, latent-age children who our parents were very pleased with, and we became strangers in disguise to our parents. We were non-communicative, surly, slam doors in faces and sort of things, and it's sort of like that. And then by the time we were a bit older, that had gone away too. So I'm not saying these people had no moods, but it wasn't like, if your patient after several years of treatment is still so moody when you make a narcissistic slip and hurt their feelings, that they go into a rage, that symptom hasn't gone away. But most people, it sort of has. It's like, she says something dumb again, but okay. In general, she's sort of useful. I'm not going to have a rage attack. That's sort of the tail end of affective lability. So thank you very much.